Hello everyone, I am Alison Margary and it gives me great pleasure as President of the British Occupational Hygiene Society to speak to you at this your annual conference of the Australian Institute of Occupational Hygiene. I know that I am one in an illustrious line of speakers to have had that pleasure. I think in particular of Dr. Peter Hewitt, who sadly died in January, a former BOHS president amongst many other accomplishments, but who cherished little more in his international engagements than visiting Australia to engage in discussions with hygienists. It might be said that hygienists talk a universal language, not least because the science and the issues are consistent across the globe. I am just sorry that I am not with you in person. I had hoped that the timing of the conference, having been moved from end November to late March, and with Australia starting to open up, that this would be possible. But when looking into the visa requirements in early January, it became clear that I unfortunately didn't fit into any of the COVID exemption criteria. And the further relaxation of the rules from the end of Feb was sadly a bit late to be sure of arranging the necessary paperwork and travel in a timely way. Not to mention the concern to avoid catching COVID at the critical moment of travel, scuppering any plans. Indeed, having avoided catching COVID for 2 years, I succumbed just in the past couple of weeks. The Omicron variant is still very much alive and circulating in the UK as I speak. So I think, all things considered, it was sadly the right decision. But if there are positives from the pandemic, I think it is fair to say that it has brought our various health communities closer together, and I'm pleased to say given a louder voice to occupational hygiene and our prevention message. From my UK stance, I have seen this with our collaborations within our borders, but also with colleagues across international borders. It got me thinking that a good topic for my session today might be to look at occupational hygiene from the perspective of the UK and Australia. Hence my title, Occupational Hygiene in the UK and Australia, Not Poles Apart. So with that, I'd like to share my screen and my presentation slides. Perhaps I may be permitted to introduce myself and what brought me to the role of president. Like many, I didn't set out in my career to become an occupational hygienist. This is not a profession I had heard of until I found myself working as a health and safety advisor for Shell UK's corporate health and safety department in the early 80s. One of my first challenges was supporting oversight of the removal and encapsulation of asbestos, which proliferated in the buildings of the company's many premises at that time. Managing the risk of Legionella quickly followed, with 1976 seeing the first cases of Legionnaire's disease, and by the 80s, focus was initially on water cooling towers, but then turned to other water sources with aerosol potential. And I worked through the proliferation of VDUs, now referred to as display screen equipment, causing eye strain, repetitive strain injury, or RSI, a term coined in Australia, as I recall, and changed to the rather less snappy work-related upper limb disorders here in the UK, and stress as female workers worried about potential for miscarriages from non-ionising radiation emitted by the screens. Perhaps those amongst you of my era recall a similar set of challenges, which of course are still with us today. This set me on the path of training to be an occupational hygienist within the energy and petrochemical sector. On reflection, I realised that I surfed the wave of regulatory change within the UK from the Health and Safety at Work Act, which was starting to properly bed down by the early 80s, introducing a risk-based approach to managing health and safety, through the control of asbestos and control of substances hazardous to health regulations, through the explosion of European directives, to the classification, labelling and packaging regulations, improving information available on the hazards and safe handling measures for chemicals, and most recently, REACH, the registration, evaluation and authorisation of chemicals requiring detailed hazard information for all chemical substances placed on the market, and introducing exposure scenarios requiring suppliers to carry out chemical, health, safety and environmental assessments and advise on safe handling for all the uses of the chemical throughout the supply chain for substances classified as hazardous. I might say a mammoth ongoing challenge. After my start in Shell UK, I then branched out into Shell International's operations, coinciding with a big globalization drive in the 90s and noughties. Exciting times as the company rolled out its HSE management system standards, including health risk management processes as a core requirement in which I was closely involved. More recently, I had the opportunity to branch out and become my own boss and also give myself more time for voluntary activities. And now here I am as president of BOHS, something I hadn't anticipated, but I'm delighted and honoured to have been given the opportunity to take on the mantle and do what I can to support the profession I love and has given me a fascinating and worthwhile career I could only dream of back in the 80s when I started out. Now to my theme of occupational hygiene in the UK and Australia. I like to think that the relationship between our two societies is a particularly strong one, and members such as Sharon Johnson have been consistent to both professional organisations for decades. Our collaborations have been several and fruitful, most recently in the context of the Breathe Freely campaign, where Sharon has contributed so much. The example of Breathe Freely is probably one of the best illustrations of collaboration at its best. If Breathe Freely had started in Australia rather than in the UK, I would like to think that it would have ended up in the same place. If you will indulge me, I would like to trace just how our collaboration has developed and what it says about the importance of our organisations working together. With the opportunity to address you, it would be remiss of me as president of BOHS not to mention the importance of our professional ties. Breathe Freely developed 5 years ago out of a realisation the occupational hygiene in the UK was persistent in some industries, such as the large-scale manufacturing, pharmaceutical, energy and petrochemical sectors, but not a discipline that was informing others. We focused on bringing an awareness to the construction because of the size of construction as an employment sector, the risks in the sector, and because it was perhaps ready to focus on health as well as safety. Volunteers worked hard to produce accessible guidance on occupational hygiene, while champions ran roadshows and partners shared and promoted the content. The enduring legacy is the body of technical and guidance materials on the Breathe Freely site. In 2018 and into 2019, my predecessor, Neil Grace, responded to a request from AIOH to replicate these materials and to modify, expand and develop them for the Australian workplace. Thus Breathe Freely Australia was born, and from it, ASIAN, Breathe Freely New Zealand. Significant enhancements to the content reflected the respirable crystalline silica RCS challenges that Australia was already working on, as well as reflecting the dimension of climate and types of industry in Australia. In the UK, Breathe Freely gained a huge amount of traction in upper tier construction companies and in metalworking. Now, major infrastructure projects all have occupational hygiene input, and very few, if any, construction companies of scale do not have an occupational hygiene lead. However, more prosaic factors did impact on Breathe Freely in the UK. The web architecture upon which it was built turned out to be a foundation of sand. Our head office team found that the site was no longer stable and were faced with quotes of tens of thousands of pounds to rebuild it again. So we wondered how AIOH had managed to build a site that was in many ways superior to ours. Reaching out, we realised that cloning back the site from Australia's more stable web architecture was more viable than building it afresh. This we did, saving time and indeed lots of money, while acquiring really welcome new content. Thanks to AIOH, Breathe Freely UK is refreshed, technically improved and sustainable. In the discussions that ensued, as part of the process, AIOH suggested that if BOHS could clone the site, then others could too. Putting a call out through IOHA, we made the opportunity for Breathe Freely to become more widely available a reality. Last year, the Canadian Registration Board of Occupational Hygienists and the American Industrial Hygiene Association both came on board as Breathe Freely partners. As a result of this collaboration, the majority of the English-speaking world will have access to relevant and invaluable guidance on occupational hygiene, making it one of the biggest standing global campaigns in occupational health in the world. Key elements of the success of this are right at the heart of why working together in occupational hygiene is so important. Every new president of BOHS picks a theme for their presidential year. My chosen theme was partnership. It's a word that is often bandied around, but perhaps not always honoured through action. The partnership that brings to life a global sustainable vision for Breathe Freely, arising out of our partnership with AIOH, is certainly a real highlight of my presidential year. The Breathe Freely website's present and future are visible evidence of the importance of partnership in action. While I know our CEO, Kevin Bampton, is delighted that we were able to balance the budget thanks to the support of AIOH. Breathe Freely has been registered as a headline project for the United Nations Sustainable Development Goals. It impacts directly on the goals for health, decent work, and the environment. It also highlights the importance of another goal of promoting partnerships for development. Occupational hygienists, like Dr. Peter Hewitt, have long been internationalists. Perhaps this is promoted by the influence of globalization in corporate life, which brings hygienists together from across the world. However, I feel that it goes beyond this. Our founders, people like David Hickish, who drew their inspiration from the work that they saw in other countries. BOHS would not exist but for the inspiration drawn by Hickish from what he saw in the industrial hygiene sector in the United States. That global inspiration is no less important now. It is this notion of collective insight and inspiration that is the focus of my observations today. In the year of my presidency, AIOH also had another unexpected but profound influence on BOHS. In 2020, the onset of COVID-19 was a shock to BOHS as much as to many other societies. We questioned what the role of occupational hygiene was in what was portrayed as a public health crisis. Occupational hygiene was also exposed in the UK as a profession and discipline that had become unknown in some areas of society and which had lost its visibility in political life, buried deep within the infrastructure of our Health and Safety Executive, the arm's-length government agency entrusted to regulate health and safety at work. Our COVID-19 expert group drew upon a European and transatlantic expertise base initially, constituting those countries where COVID-19 had been allowed to take root. They formulated guidance for workplaces and were the first to also consider that the return to work after lockdowns was a challenge that needed to be managed. However, the looming and persistent pain for the society was the daily images of healthcare workers shrouded in ill-fitting PPE or deprived of the basic protections that any occupational hygienist would recognise as essential when dealing with a poorly understood respirable exposure. Leaders of the society met 3 times a week and worked tirelessly through every avenue they could to try and bring occupational hygiene principles to the largest employer in the United Kingdom, the NHS. With 1.2 million workers, the Society discovered that there were practically no hygienists at all in UK hospitals and health settings, and no direct or indirect routes to healthcare, with the Health and Safety Executive having largely abdicated responsibility for the management of health risks in that sector. At the same time, BOHS discovered that it had no political traction or routes to influence through government and policy. Occupational hygiene had been a term frequently and consistently used in the formulation of national health policy for many decades, but its last use in Parliament was in 1984, the year before Peter Hewitt became president. After that time, the discipline and the society had ceased to be a concept in legislative and policy discourse on a national level. It was only in July of 2021 that, through the offices of Professor Raymond Aegis, a former president of BOHS, who had been brought into the board of the British Medical Association, that we found a route in to engage with the UK health professions. The professions have been working without success to move UK infection prevention and control guidance from a position which denied the airborne route for transmission of COVID-19 and therefore denied healthcare workers RPE unless undertaking aerosol generating procedures, a narrow list of medical procedures which were thought to cause the generation of infectious droplets. It goes without saying that, but for Raymond's explanation that occupational hygiene was something that was more than a posh word for cleaning, we would not have got a hearing. However, it was AIOH that actually gave us credibility. A microbiologist advising the health professions had reached out to colleagues in Australia. They, in turn, directed her to a risk assessment tool being developed for healthcare in Australia under the leadership of AIOH. BOHS was quite literally asked whether we could produce something like that. Precisely how AIOH managed to be at the centre of national infection control for COVID-19 is something we would really like to understand. Somewhere along the line, the connective tissues between health and national policy that AIOH has were lost by BOHS. BOHS were then able to work with the UK health professions to develop a comprehensive toolkit for seasonal respirable diseases, which went live on the website of the Royal College of Nursing on Christmas Eve. Behind the scenes, BOHS reframed the debate between the healthcare professions from being one around infection prevention and control to one about healthcare worker health protection, and on January the 18th, 2022, the Westminster Cabinet Office guidance changed to focus on the management of risk of airborne transmission, promoting a risk assessment matrix which bore a remarkable resemblance to the BOHS RCN tool and which clearly shares its intellectual DNA with the AIOH tool. It is humbling to think that the credibility of UK occupational hygiene with our largest single workforce rested on the credibility of the work of AIOH. As a result of this, BOHS is now regarded as a strong and reliable partner by a significant group of health professional bodies who had never heard of the organisation or profession. More importantly, the role and function of occupational hygienists and their vital role has been recognised by the major health bodies who are now beginning to demand the return of occupational hygiene to their workplaces. As president of BOHS, I have greatly valued our recent rounds of meetings with AIOH and our American colleagues in AIHA and the potential for collaboration we have highlighted in them. The relationships between our professional families continue to be strong, even if COVID-19 keeps us to Zoom calls. However, the examples of the influence of AIOH on BOHS in this address remain special and highlight that beyond technical sharing, partnership and influence makes the global of local relevance. Without AIOH, we would not have had the impact that we are having, and for that, it gives me real and genuine pleasure to thank you. As president of BOHS, I am taking the liberty of not talking about the sort of wonderful scientific and practical developments that make this conference so vibrant and interesting. Instead, I hope that you will allow me to discuss more generally my reflections on the role of our organisations like ours in the context of contemporary challenges. In reflecting on the Australian experience, it has helped me think about our own role as the UK's Chartered Society for Worker Health Protection and what we can learn from your experience and the Australian context. With Breathe Freely, BOHS accepted that for whole sections of industry in the UK, occupational hygiene was an alien concept and term that we would need to engage systematically and seriously with people beyond the traditional client group for occupational hygiene. It was a recognition that there had been years of introversion where its focus in the UK had been on science and practice of OH, but almost as a dispassionate academic discipline. Many of our members today focus within that on the important job of measurement and monitoring, and from that drawing recommendations for change, working in traditional industrial settings. And we will likely always need this skill set and capability. However, alongside the perfection of the arts of exposure monitoring are looming gaps in knowledge, which continue to undermine the impact of what can be done with such data. A significant issue is a lack of real understanding of control effectiveness. This relates to both systematic understanding of control efficiencies through to a more general understanding of the patterns of risks in working populations and the availability and use of controls within sectors through to the epidemiology of occupational diseases. A case in point is silica data, where much of our understanding in the UK is still built largely on a data set from Canada, which is decades old. In some ways, we could and indeed had to ignore this problem when we were part of the European Union. It was the Commission and European Parliament which set OELs based on assumptions of control efficiency where there was no real option but to follow them. But now we are out of Europe and the UK government is putting even more emphasis on control to as low as reasonably practicable, a LARP, and we lose the benefit or limitation of ECHA-based workplace indicative limit values. In the public sphere, however, there is no national UK research agenda. In the private voluntary sphere, even the leading charity on respiratory health in the UK, the Task Force on Lung Health, while mentioning Breathe Freely, mistitles BOHS as the British Occupational Health Society and omits from its strategy for occupational lung health any mention of the concept of occupational hygiene or of the role of occupational hygienists. Indeed, it signifies how Breathe Freely was a significant and important first step in the recognition that occupational hygiene is more than the function of exposure monitoring. In recent years, the leadership of BOHS has been taking a leaf out of the environmental lobby and moving from a focus on monitoring control and OH remediation to understanding that influencing policy and public perception are vital to effective prevention and a genuine approach to the precautionary principle. We have dubbed this sustainable workplace health. It looks at workplace health in a broader context than exposure science, grounded in an appreciation of risk at the design stage and an understanding of human and public cost calculated through whole life exposure, but also illness and loss of life. To take the environmental analogy further, environmentalists are moving from trying to measure the amount of plastics in the oceans and removing it to looking at the removal of plastics from the product cycle and understanding the long-term effect on human health, animal health, and the environment of long-life microplastics. Setting an OEL and hoping exposures will not exceed this is akin to continuing to sell plastics but setting a higher target for recycling. In the UK, official figures suggest that 50% of plastic is sent for recycling, although Greenpeace claims this is really only 10%. As much as 80% of recyclable materials goes for incineration, according to a Guardian newspaper report in August 2019. Recycling is possible and is an objective, but a plastic item is still single use if only used once and then burned, even if it is recyclable. Having control measures, exposure monitoring, and an OEL does not guarantee that workers will be protected. The UK's regulator, the Health and Safety Inspectorate, routinely discovers that such commonplace controls as LEV are not specified properly or not properly located to control exposures or are not operated effectively or simply are not switched on. On building sites throughout the UK, dust masks are visible, yet as PPE their effectiveness is questionable, and they are a clear indicator that many construction sites have not made serious efforts to reduce the commonplace construction dust hazards that contributes to the 12,000 estimated deaths per annum. This highlights that the real challenge for occupational hygiene in the UK is not to understand the level of exposure, but for the government, employers and workers to take the risks, many of which are known, seriously. It is also vital to get the message through to the boards, designers, project planners, accountants and insurers who drive decision making to understand the risks and the costs. The workplace will continue to throw up scientific challenges and new opportunities to monitor and understand exposures, and BOHS is working harder than ever to be at the forefront of that work. However, COVID-19 woke us up to the fact that being an authority in the novel and routine science of health protection in traditional industries does not get you a seat at the table when occupational hygiene can be of most use. At the genesis of BOHS, the understanding of the relationship between the working environment and novel exposures was still in its infancy. Its founders were seen as rare creatures brought in to solve the mystery of unexplained illnesses. Over the years, occupational hygiene became embedded in the national infrastructure with occupational hygiene centres throughout the country and an annual report to Parliament on occupational hygiene, on occupational health and occupational hygiene, representing distinct and complementary disciplines. The decline in the centrality of occupational hygiene to British public health policy coincided, not unexpectedly, with the decline of British manufacturing and the increased integration into the European Union, which took over competency for standards in worker health protection. It was absorbed into occupational health for the purposes of national policy making in the 70s, on the pretext that occupational hygiene was at the heart of what any good occupational health practitioner did. Perhaps symbolic of the decline in the public policy profile of BOHS was that its last serious mention in Parliament was in 1984, the year of the coal miners' strike. In contrast, in 1980s Australia, the Institute was just being set up. The growth of AIOH has been notable, with 1,000 members, of which 400 are hygienists for 30 million workers, still leaves a lot of work to spread around. However, there are 1,400 BOHS members, of which 700 are hygienists and 32 million British workers. That means there are 50% more industrial hygienists in Australia per head of population than in the UK. Believing that we can monitor our way out of the health crisis in the occupational sphere that accounts for at least 1.6 million people suffering work-related illness against a working population of 32 million is probably unreasonable. It appears, at least to me, looking at it from the other side of the world, the AIOH has managed to gain a place within the decision-making processes for health and legislation. As the UK has drifted away from occupational hygiene, Australia in some ways seems to have embraced it, and indeed the nature of the risk it addresses. This may be down to the success of stalwart leaders such as Kate Cole and Sharon Johnson, or the power of the Institute as a whole, or indeed a more enlightened government. Of real importance is the partnership between industrial hygienists in Australia and the medical profession. It seems clear that closer working relationship in this space is of critical importance. Each BOHS president has a theme for their year. Mine was partnership. This may seem like motherhood and apple pie to some, but it has been of critical importance to the BOH's fate over recent months, as we have realised that the mission to develop sustainable workplace health in the UK cannot rest entirely or even largely in the hands of a small group of professional hygienists. However, beyond partnership, we need to be prepared to be bolder. The AIOH Foundation paper on the inadequacy of Australia's workplace data was a hard-hitting one which BOHS, even with an appetite for more vocal opinions, might not have published itself. However, while the point of the paper, that Australia does not publish headline figures in the same way as the UK HSE, is an important one, there are other considerations. Australia is thought to have a bigger problem with silica. This is largely on account of the 271,000 people working in the mining industry, combined with the growing workforce of 1.14 million people employed in construction. In the UK, construction could account for between 6% and 9% of the UK working population, depending on which government department you refer to and when. The Office for National Statistics suggests 6%, and the construction sector, drawing from the ONS data, concludes closer to 7%. In fact, when digging through the statistics upon which risk models for the UK are based, the consistent factor was inconsistency of the potentially exposed group in the UK. In fairness, the absence of real data is something that the UK is aware of and has been working with Manchester University, Freudian slip, to create a database that may enable exposure levels to be more accurately estimated. Conversely, the UK mortality statistics are not what they seem to be either. While the current HSE website suggests the figure of deaths from occupational-related silica-induced cancer could be 500 or 450, depending on which page you look at on their website, the statistics for counting occupational deaths don't count deaths over the age of 75, which may be occupationally related. While the absence of systematic data collection in Australia creates a problem of not really knowing what the scale of the problem is, the absence of reliable statistics in the UK means that the problem may actually be misunderstood. With a lower occupational exposure limit in Australia, 0.05 milligrams per metre cubed, other than Tasmania at 0.1 milligrams per metre cubed, means that more Australian workers are highlighted as being exposed at a higher level than in the UK. Even prior to the lowering of the exposure limit in the UK, the 2011 figures for exposure from Australia's Cancer Council, 2011, suggested the exposure rate as being around half of the workforce in construction and mining at the time, as opposed to 65% of the workforce in the UK estimated to be exposed, as cited by IOSH, the Institute of Occupational Safety and Health. However, the scale of the problem in 2020's all-party parliamentary group report was stated as 600,000, roughly the same as the number of people exposed in Australia, despite the UK having a construction sector at least double that of Australia. As hygienists, we are used to statistics and aware of the misuse of statistics as well. While I would not suggest that the UK government is somehow trying to hide the truth, the presence of statistical data in this field is probably not doing much to drive sensible policy. So what can we do to make a difference? Certainly, much power for change lies with the legislators of our countries. It is clear that AIOH members have had a critical role in driving state, if not national level legislation. In the UK, the all-party parliamentary group's report on silica is probably one of the most important publications in the field of occupational health in many years. Yet it mentions occupational hygiene only once. This is not for want of trying to get a hearing. The Society put forward credible and compelling evidence, but it appeared to be glossed over. In recent years, however, again prompted by our experiences with COVID, BOHS has taken to be a bit more vocal. We have started using science not just to monitor things, but to create a narrative about how policy needs to change to support the changes needed in the workplace. Late last year, we put forward evidence to the UK Parliament on the weaknesses of the implementation of the control of asbestos regulations. To our surprise, for the first time since 1984, the Society appeared again in Hansard, so we were invited to give oral evidence. Then, out of the blue, the all-party parliamentary group contacted us to say that they felt the report had overlooked the vital role of prevention, and would BOHS provide more evidence for a supplementary report on prevention. It may be that in being more vocal, we have found an audience. Our aspiration in the end will be to ensure that there is more influence for occupational hygiene within the legislature, within policy circles, and with our regulators. We are still a little way off from the apparent influence that you have in Australia. However, we are hopeful. In summary, perhaps what reviewing our relationship of recent years and our relative positions, we probably need to be a bit more Aussie and a little less pommy. Thank you for your attention, and I will be pleased to hear your comments and any questions.